Normal labor. Process by which a fetus after attaining period of viability is expelled from the genital tract. Criteria of normal labor: spontaneous onset, term gestation, that is 32 to 42 weeks, vertex presentation, uncomplicated delivery, vaginal delivery is all normal labor. Phases and onset of labor. Phases of labor: phase 1, uterine quiescence, uterus is unresponsive, cervix is soft, main hormone progesterone. Phase 3, phase of uterine stimulation and contraction, all stages of labor included. Phase 2, myometrial activation, preparatory phase. Function: so phase 1 is uterine quiescence, phase 2 is myometrial activation, preparatory phase. Functional withdrawal of progesterone, increase estrogen level, increase oxytocin receptors, increase prostaglandin receptors, increased gap junction, ripening of cervix. Phase 3, phase of uterine stimulation, contraction, all stages of labor included. Phase 4, postpartum phase. Onset of labor: fetal hypothalamus, corticotropin releasing hormone goes to fetal pituitary gland, adrenocorticotropic hormone goes to fetal adrenal gland, releases DHEA sulfate in placenta, it gets converted to estrogen, causes uterine contractions. Process of labor: pre-labor state, lightening welcome sign, descent of fetal head into pelvis, decrease fundal height, relieves respiratory distress, false labor pains, cervical ripening, becomes soft and dilates due to prostaglandin, cause connective tissue changes, decreased cross-linking of fibers, increase water content, increase hyaluronic acid. Bishop score should be done prior to induction of labor to assess cervix. True versus false labor. True labor pain, false labor pain. Uterine contraction, regular and rhythmic. True. Irregular, continuous. False. So true labor pain increases progressively in intensity, frequency, and strength. In false labor pain, there is no such increase. True labor pain culminates in cervical dilation, but the false labor pain does not lead to cervical dilation. Site of pain in true labor pain is lower abdomen and radiates to the back of the thigh. There is no radiation in false labor pain, it's just lower abdomen. True labor pain shows mucosal blood and plug in show, but it's not so in false. Bag of membranes is felt in true labor pain but not felt in false labor pain. Response to sedation, enema, rest there is no response in true labor pains, but false labor pains go away by this. Stages of labor. True labor pain begins. First stage, full dilation of cervix, 10 cm. Second stage, delivery of baby. Third stage, delivery of placenta. Fourth stage, 1 to 2 hours after delivery of placenta. Observation period. Requirement of labor. Mnemonics 3 P's. Push, uterine contraction, passage, pelvis, passenger, baby. Uterine contraction. Origin: cornua of uterus. Speed 2 cm per second. Time to depolarize enteral uterus 15 seconds. Predominant contraction site fundus. Adequate contractions, 3 contractions in 10 minutes, last for 45 seconds. Increase intrauterine pressure by 65 to 75 mmHg, 200 to 210 Montevideo units. Strength of contractions palpable at 10 mmHg, painful at 15 mmHg. Cervical dilation at 20 to 50 mmHg. 20 to 25 mmHg. During stages of labor: first stage 40 to 50 mmHg, second and third stage 100 to 120 mmHg. Basal tone released 10 to 20 mmHg. Monitoring every 30 minutes. Note: 1 Montevideo unit equal to strength of uterine contractions in mmHg into number of contractions in 10 minutes. So, blood flow in uterus decreases during contraction. As pregnancy advances, upper uterine segment formed by entire uterus contracts during labor. Lower uterine segment formed by isthmus passively dilates during labor. At first stage of labor, effacement of cervix becomes part of lower uterine segment. Tachysystole. More than 5 contractions in 10 minutes. Cause: misoprost, more common than oxytocin. Consequences: fetal distress due to decreased blood supply. Cardiotropography, prolonged deacceleration. Management: stop oxytocin, turn mother to left lateral position, O2 inhalation by mask, IV fluids if required, terbutaline, uterine relaxant. Precipitate labor, entire process of labor completes in less than 3 hours. Consequences: perineal tear, hematoma, postpartum hemorrhage. Hypotonic contractions leads to prolonged slow progress of labor. Management: augmentation of labor by artificial rupture of membranes, oxytocin. Augmentation of labor, artificial rupture of membranes. Instrument used is Kocher's forceps, single tooth, multiple rat-like teeth, ratchet lock, transverse serrations. Principal: rupture of membranes, release of prostaglandin E1, augmentation of labor. Contraindications: absolute. Maternal HIV, genital herpes infection, intrauterine death of fetus. Relator: polyhydramnios due to increased risk of abruptio placenta. Controlled rupture of membrane stun, hole made in the membrane, slow release of amniotic fluid. ARM is beneficial in abruptio placenta due to abrupt rupture of membrane is beneficial in abruptio placenta due to it confirms the diagnosis, accelerates process of labor. Indication of augmentation of labor: slow progress of labor, dilation of cervix less than 1 cm per hour in active phase. Sequence: if head engaged, abrupt artificial rupture of membranes, 30 minutes, oxytocin. If head is not engaged, increased risk of cord prolapse, oxytocin followed by artificial rupture of membrane. Cardinal movements of labor: engagement, descent, flexion, internal rotation and crowning, extension, delivery of head, external rotation, restitution, expulsion of baby. Normal delivery: longitudinal lie, cephalic presentation, presenting part is vertex. Process of labor: head in LOT position, most common is LOT, more common than LOA. Engagement of head, descent of fetal head onto levator ani muscle, flexion of head, internal rotation, occiput rotates by 2/8 of a circle at the level of ischial spine, 45% by neck, 45% by shoulders, crowning head seen at labia irrespective of contractions, episiotomy given if required only, extension for delivery of head, untwisting of neck, restitution, external rotation, shoulder rotates by 1/8 of a circle, visible as head rotates, occiput in LOT position, expulsion of the baby. Methods to prevent perineal tear. WHO recommendations. Perineal massage, warm towel at perineum. Support perineum with hand. Flex head initially, followed by extension for delivery. Engagement. Definition. Largest transverse diameter by parietal diameter of fetal head crosses pelvic inlet. In primigravida at 38 weeks, in multigravida at time of labor. Signs of engagement. On per vaginal examination, O station, 0 station. Causes of unengagement in primigravida at birth. Deflexed head. Most common. Cephalopelvic disproportion. More common than placenta previa. Other causes: polyhydramnios, wrong dates. Note: placenta previa to be ruled out before performing vaginal examination in a primigravida with free floating head. Again, placenta previa needs to be ruled out in a primigravida with no engagement at 38 weeks and a free floating head before vaginal examination. Engagement rules out CPD at level of inlet. Engaging AP diameter depends on degree of flexion of head. Degree of flexion, presenting part, engaging AP diameter. Fully flexed, deflexed, partially extended, fully extended. So fully flexed vertex, deflexed vertex, partially extended brow, fully extended face. Engaging AP diameter. Fully flexed sub-occipitopragmatic AP diameter. Deflexed occipitofrontal. Partially extended mento-vertical. C-section, fully extended submento-vertical and submento-pragmatic. Synclitic engagement. Sagittal suture lines in transverse diameter of pelvis, midway between pubic symphysis and sacral promontory, in LOT position. Asynclitic engagement. Head is deflected anteriorly and posteriorly. Defined in terms of parietal bone of head, fetal head. Anterior asynclitism, sagittal suture deflected towards sacrum. Anterior parietal presentation, better prognosis. Posterior asynclitism, sagittal suture deflected towards pubic symphysis, posterior parietal presentation. Head of baby delivered by extension, in vertex, flexion, in breech and face. Pain during labor, during first stage and during second stage. So, pain during labor, during first stage, uterine contraction radiates to thoracic 10 to lumbar 1, plus dilatation of cervix radiates to S2 to S4. Epidural analgesia. Level of block, T10 segment. Sensory plus sympathetic block, no motor block. Drug of choice. Bupivacaine, 0.625%. Ropivacaine. Monitoring BP, fetal heart rate, first stage of labor. Second stage of labor, dilatation of cervix, radiates to S2 to S4, plus stretching of perineum, pudendal nerve, S2 to S4. Effects: shortens first stage of labor, prolongs second stage of labor by 1 hour. Contraindications is anticoagulant, uses 12-24 hours prior to the onset of labor. During C-section, anesthesia is given at T4 segment. Blocks pain from peritoneum. Epidural anesthesia does not increase rate of C-section. Pudendal nerve block. Site ischial spine. Ligament pierce sacrospinous ligament. Pain relieved in second stage of labor. Ischial tuberosity, ischial spine, sacrospinous ligament. Pudendal nerve block. Use instrumental delivery, repair of perianal vaginal tear. Pudendal nerve block does not block pain during repair of cervical tears. Paracervical block. Sites 2 o'clock and 4 o'clock, 8 o'clock and 10 o'clock. Sites avoided 3 o'clock and 9 o'clock due to descending cervical artery. Duration of block 1 to 2 hours. Uses repair of cervix, suction and evacuation. Contraindicated use in labor. Causes fetal bradycardia. Prostaglandins. Receptors. G protein cell membrane receptors. Present on myometrium and cervix. Releases local release paracrine action. Synthesis decidua and myometrium. PGF2 alpha uterine action. Amnion PGE to act on cervix. Uses induction of labor, sweeping of fingers in internal os to separate membrane, release of prostaglandin E2, ripening of cervix, augmentation of labor, management of postpartum haemorrhage. Induction of labor, initiation of uterine contraction in a patient not in labor. Bishop's score, parameters, checks readiness of cervix and uterus before induction of labor. Maximum score is 13. This is how it is scored. So parameter and score 0, 1, 2, 3. First is dilatation of cervix. Second, position of cervix, effacement of cervix, situation of fetal head, and consistency of cervix. So 4 things are of cervix and 1 is of fetal head. So the 4 thing about cervix is dilatation, position, effacement, and consistency. And the last thing is station of fetal head. So dilatation again has 0, 1, 2, 3 scores. So 0, it's closed at 0, up to 2 centimeters at 1, 4 at 2, and more than equal to 5 is 3. Position. Posterior is 0, middle is 1, anterior is 2. Effacement 30%, 0, up to 50% is 1, and up to 70% is 2, and 80% is 3. Consistency, firm is 0, medium consistency is 1, and soft consistency is 2. Station of the fetal head, above -2 is 0, -2 is 1, -1 or station 0 is 2. So you have to remember -1 is 2. So -1 and 0, station is 2. Below ischial spine is 3. Most important parameter is dilatation. Least important parameter is position. Simplified Bishop's score. Dilatation of cervix, effacement of cervix, station of fetal head. Maximum score is 9 and here maximum score was 13. Interpretation. Less than 5 cervix not ripe. Induction of labor will not be successful. More than 6 cervix favorable for induction of labor. More than 9 chances of vaginal delivery similar to spontaneous labor. Modified Bishop's score. Placement of cervix replaced by length of cervix, measured by ultrasound. Methods of induction of labor. Cervix ripening will lead to induction of labor, then augmentation. Cervix ripening, sweeping of membranes, mechanical, prostaglandin. Induction of labor, mechanical, prostaglandins, oxytocin. Augmentation, oxytocin, artificial rupture of membranes. Sweeping of membranes, also known as stripping of membranes. Indication, cervix slightly dilated. Principle, sweeping membranes detached from cervix, release of prostaglandin, ripening of cervix. Mechanical methods, ripen cervix plus induced labor, preferred in scarred uterus. Methods, first one is done in normally in labor room, is transcervical Foley's catheter, number 16 inserted. So here with this method, what we are doing is induction of labor. What we are doing is sweeping of membranes. So the Foley's catheter number 16 to be used, endocervical bulb sits at level of internal os, inflates bulb with 30 ml NS, stretching of cervix, prostaglandins released. Then second is extra amniotic saline infusion, insert Foley's catheter into endocervical canal, inflate bulb with normal saline 30 to 40 milliliter per hour, collection of normal saline in amniotic fluid, separation of membranes, prostaglandins release. Amnion, chorion 30 ml. Third one is hydroscopic dilate, laminaria tent. Prostaglandins, contraindicated in scarred uterus. Side effect is tachysystole, cervidile more than cerviprime more than misoprostol. Misoprostol. Administration, 25 microgram orally vaginally, repeated 3 to 6 hourly, that is 4 hours. Maximum 6 doses, 4-hour gap. No induction of labor, then oxytocin. Side effects, fetal heart rate abnormalities, meconium staining in newborn. Dinoproston, PGE2. Cerviprime gel. Dose 0.5 milligram, inserted in cervix, repeated 6 hourly, max 3 doses. After 6 hours, oxytocin, refrigerated. Dinoproston gel, Cervidil. Dose 10 milligram, release 0.3 milligram per hour. Inserted posterior of the fornix, kept in vagina 12 hours until patient goes into labor. Oxytocin, contraindication, ripe. Use oxytocin directly. Not ripe, ripen cervix, then use oxytocin. So oxytocin use ripe and not ripe. Ripe, use oxytocin directly. Not ripe, first ripe and then use oxytocin. Administration, 5 units oxytocin plus 500 ml NS. You have to mix that. Then 10 ml international MIU per ml of oxytocin equals to 0.5 MIU per drop. Max dose 52 drops per minute. So 5 unit of oxytocin in 500 ml NS, and maximum dose that you can give is up to 52 drops per minute. Side effect: water intoxication, hyponatremia if dissolved in 5% dextrose, hypotension if drop rate increases. Contraindication for induction of labor: conditions where vaginal delivery is contraindicated is also obviously contraindication for induction of labor, such as placenta previa, vasa previa, malpresentation like transverse lie, bro, mentoposterior phase, active genital herpes, contracted pelvis, CPD, cephalopelvic disproportion, cancer of cervix, previous history, classical C-section, myomectomy, fetal distress, monochorionic, monoamniotic, twins, conjoined twins, because they won't be delivered one after the other. Induction of labor in special cases: scarred uterus, mechanical method, ripening, and then oxytocin. Induction of intrauterine death of fetus: 20 to 28 weeks, misoprostol 800 to 800 microgram per vaginally, repeat 400 milligram 3 hourly, more than 28 weeks, 25 milligram misoprostol, ripen cervix, and then oxytocin. Active management of third stage of labor. Third stage of labor starts after delivery of baby, ends delivery of placenta. Main event: main factor affecting placental separation, uterine contractions, plane of separation through zona spongiosa, most common method of separation, School's method, shortest sign, placenta felt in vagina, more than apparent plus permanent lengthening of cord. Management: after delivery of baby, passive management not preferred. Wait for placenta to be expelled spontaneously, duration 15 minutes. Increased blood loss, increased risk of postpartum hemorrhage, maternal mortality. Active management of third stage of labor preferred due to decreased duration of third stage, 5 to 10 minutes, blood loss decreased, best method to prevent postpartum hemorrhage, decreased risk of maternal mortality. Drawback: increased chances of retained placenta, use of uterotonics. Steps of management: inject uterotonic to mother less than 1 minute of delivery or at the time of delivery of anterior shoulder. Delayed cord clamping, delivery of placenta by controlled traction, intermittent assessment of uterine tone, uterine massage, previously fourth step, treatment of postpartum hemorrhage, early cord clamping not done, inactive management of third stage of labor. Step 1. WHO recommendations: injection oxytocin, 10 intrauterine, 10 international units by IM or IV infusion in ringal lactate or normal saline, stored at 2 to 8 degrees Celsius. Contraindication: IV bolus, hypotension, tachycardia, cardiac arrhythmias, cardiac arrest, dextrose 5% preparation, water intoxication due to antidiuretic effects. If oxytocin unavailable, methyl ergometrine 0.2 mg IM, IV avoided due to severe hypertension. Stored at room temperature. Symptometrine, fixed dose combination of 5 unit oxytocin plus 0.5 methyl ergometrin. Advantage, increased efficacy. Disadvantage, expensive and less availability. Carboprost, synthetic oxytocin, octapeptide is carboprost. Dose 100 micrograms slow IV over 1 minute. T half is 40 minutes, while T half of oxytocin is 3 to 5 minutes. Duration of actions 3 hours, not used for induction, augmentation of labor, or postpartum management. Misoprost, prostaglandin E1. Dose 600 microgram tablets orally or sublingually. Range 400 to 600 microgram. Differences between oxytocin and methyl ergometrin. Types of contraction, oxytocin and methyl ergometrin. In oxytocin, physiological contractions occurs at regular interval, relaxation between contractions to allow blood flow to fetus. Methyl ergometrin, tetanic contractions plus no relaxation may cause fetal distress. Acts on lower and upper uterine segments, or methyl ergometrin acts on lower uterine segments mainly. Use of oxytocin, induction of labor, augmentation of labor, preferred for active management of third stage of labor. Use of ME, methyl ergometrin, only after delivery of baby, not first line in active management of third stage of labor due to increased chance of retained placenta. Complication, hypotension with IV bolus and hypertension in methyl ergometrin. Note, carboprost or dinoproston, PGF2 alpha, and tranexamic acid is not used in active management of third stage of labor. It is reserved for management of postpartum hemorrhage. If increased risk for postpartum hemorrhage, 1 gram of tranexamic acid IV infusion in 100 ml of NS over 20 minutes plus oxytocin. Dinoproston, PGE2, used for induction and augmentation of labor. Not recommended by WHO for active management of third stage of labor and management of postpartum hemorrhage. Step 2. Delayed cord clamping. Clamping on cord more than equal to 1 minute, between 1 to 3 minutes, included in Anemia Mukt Bharat program. Advantages: 80 ml of extra cord blood, which is equal to 50 mg of elemental iron to baby, prevents neonatal anemia. Indications: all deliveries including preterm, post-term, maternal COVID-19 infection, etc. Exceptions: indication for early cord clamping, absolute, need for neonatal resuscitation, birth asphyxia, relative, RH negative mother, plus minus indirect Coombs test, negative. If ICT positive, that is if indirect Coombs test is positive, then DCC. Then you have to do delayed cord clamping. So if test is positive, that is indirect Coombs test is positive, then you have to do delayed cord clamping. Known case of heart disease in baby, overload on heart. Excessive maternal bleeding. Note, HIV positive mother, as per WHO and ACOG, you have to do delayed cord clamping. As per national guidelines, ECC, after early cord clamping after cessations of cord pulsations. Decreased risk of vertical transmission of HIV is more in artificial rupture of is more in ART than compared to cord clamping. Stages 3 and 4. Step 3, delivery of placenta. Technique use control cord traction, also known as modified Brandt-Andrews technique, should be performed by skilled birth attendant. Look for signs of placental separation. If present, push uterus upwards with one hand and gentle traction of cord during uterine contraction downwards and forwards. So this is what's most commonly done in labor rooms, is the controlled continuous cord traction. Hand stabilizes the uterus and squeezes the fundus. Grady's method is outdated. Special cases. If cord breaks, manual removal of placenta, performed under general anesthesia, using sweeping action of hand in plane between uterus and placenta. If cord pulled when placenta not separated, uterine inversion can happen. Clear plane between placenta and uterus not established due to morbidly adherent placenta accreta spectrum. Persistently bleeding after delivery of placenta plus retained part of placenta on ultrasound. Placenta subcenturiata, placenta bilobata. Intermittent assessment of uterine tone, done every 15 minutes for 1 to 2 hours. Note, prolonged third stage, retained placenta not delivered after half hour of delivery of the baby. Fourth stage of labor, first 2 hours of observation after delivery of placenta. Mother experiences physiological chills. Monitoring, parameter, uterine tone, pulse and blood pressure, repeated at every 15 minutes. Temperature at every 4 hours. Advice given to patient, pass urine and oral intake within 2 hours of delivery. Possible complications: postpartum hemorrhage, perineal tears, vulval hematomas. Postpartum hemorrhage, overview. Most common cause of maternal mortality in India. Postpartum hemorrhage, blood loss more than equal to 500 ml after vaginal delivery, more than equal to 100,000 ml after C-section. ACOG definition, blood loss more than equal to 1000 ml after any type of delivery. Clinical definition, excessive bleeding after delivery requiring blood transfusion. Blood loss associated with signs and symptoms of hypovolemia. Fall in hematocrit by more than equal to 10% between admission and postpartum period. Severe postpartum hemorrhage by WHO, blood loss more than equal to 1000 ml. Types: primary postpartum hemorrhage and secondary postpartum hemorrhage. Primary postpartum hemorrhage occurs within 24 hours of delivery, and secondary postpartum hemorrhage occurs more than 24 hours to 12 weeks of delivery. 12 weeks is like 3 months. Causes: mnemonic, tone of uterus, atonic, most common overall, most common in primary postpartum hemorrhage. Trauma, perineal cervical tear, hematoma, uterine rupture, all are coming under trauma. Thrombin, bleeding disorders. Tissue, retained placental tissue, most common in secondary postpartum hemorrhage. Most common in primary postpartum hemorrhage is atonic uterus, and most common in secondary postpartum hemorrhage is retained tissue of placenta. Note, dilation and curettage in postpartum period is highest risk for Asherman syndrome. Dilatation and curettage in postpartum period has highest risk of Asherman syndrome. Living ligature is the middle layer of myometrium. Muscle fibers compress blood vessels on contraction and stops bleeding. They are in the shape of 8. Atonic uterus, no compression, so postpartum hemorrhage. Best method to prevent postpartum hemorrhage is active management of third stage of labor. Risk factors. Risk factors for postpartum hemorrhage: maternal factors, placental factors, uterine factors, and intrapartum factors. Maternal factors: previous history of postpartum hemorrhage, advanced maternal age, obese, multigravida, increased parity, history of pregnancy-induced hypertension and current pregnancy, anemia. Placental factors: placenta previa, abruptia placenta, history of antepartum hemorrhage will be there. Placenta accreta spectrum, chorioamnionitis, uterine factors: over distension of uterus, twin pregnancy, gestational diabetes, polyhydramnios, microsomia, fibroid uterus, intrapartum factor, prolonged labor, precipitate labor completed in 3 hours, induction augmentation of labor, instrumental delivery, overuse of tocolytics, general anesthesia administration. Specific risk factors for traumatic postpartum hemorrhage: instrumental delivery, breech extraction, obstructed labor, tachysystole more than 5 contractions per minute, increased parity, multigravida, and increased maternal age. Specific risk factor for traumatic postpartum hemorrhage: instrumental delivery, breech extraction, obstructed labor, tachysystole more than 5 contractions per minute, increased parity, multigravida, and increased maternal age. Management of postpartum hemorrhage. Postpartum hemorrhage is an obstetrical emergency. In your labor room postings, you will see that all the residents will be running here and there when there is a case of postpartum hemorrhage. It is an acute emergency, life-threatening. Requires quick synchronized approach. Increased bleeding postpartum. First step, resuscitation. Insert 2 large bore IV cannula. Collect blood sample for EBO, RH grouping, CBC, BT, CT, etc. Bleeding time, clotting time, etc. Arrange for blood. Start crystalloids, that is 1000 ml per minute, ringal lactate and normal saline. Airway breathing, circulation, monitoring and maintenance. Insert Foley's catheter, plus per abdominal uterine massage. Tone of uterus normal, uterus well contracted. That rules out atonic postpartum hemorrhage and indicates there is a traumatic postpartum hemorrhage. So you do a per vaginal speculum to rule out cause of the post-traumatic hemorrhage. Now tone of uterus maintained decrease maintained only by massage indicates atonic postpartum hemorrhage. Then you do per vaginal examination to rule out retained membranes, placental parts which can induce contractions. If atonic uterus confirmed, management of atonic postpartum hemorrhage. Management of atonic postpartum hemorrhage. 3 simultaneous steps. Bimanual uterine massage plus injection clenexamic acid plus uterotonic drug. one hand on abdomen and one hand inside vagina. That is called bimanual uterine massage. Injection tranexamic acid. Administration within 3 hours of onset of postpartum hemorrhage. Dose 1 gram of tranexamic acid in 100 ml of normal saline. IV infusion over 20 minutes. Fast rate hypotension. Dose repeated if bleeding persists in more than half hour. Reappear in 12 hours. Uterotonic drugs. Oxytocin. First drug recommended by WHO is oxytocin for uterotonic drugs. Dose 20 to 40 international unit IM IV infusion. IV bolus to be avoided due to risk of hypotension, arrhythmia, myocardial infarction, cardiac arrest. IV infusion should be prepared in 5% dextrose due to water intoxication. Types, there is natural and synthetic. Natural types, nonapeptide synthesized by paraventricular nucleus or hypothalamus, stored in posterior pituitary pulsatile release. Synthetic, octapeptide stored at 2 to 8 degrees Celsius. Mechanism of action: increase intracellular calcium, increase PGF2 alpha release from residua. T-half 3 to 5 minutes. Onset of action 3 minutes. Duration of action 1 hour. IM oxytocin. Oxytocin causes after pains and milk ejections. Methyl ergometrin. Effects: tetanic contraction of uterus, continuous, cannot be used during pregnancy. Can lead to retained placenta, not first line of drug in active management of third stage of labor. Contraindication: after delivery of first twin, heart disease, peripheral vascular disease, uncomplicated preeclampsia, health syndrome, Rho negative pregnancy, HIV patients on protease inhibitors. Relative contraindication. Side effects: dose is 0.2 mg IM, repeated in 2 to 4 hours. Intravenous avoided due to sudden BP spike. Brown vials due to phototoxicity. Side effect is hypertension. Symptometry: fixed dose combination of 5 units oxytocin plus 0.5 mg methyl ergometrin. Expensive, not readily available. Carbetocin is used in active management of third stage of labor, but not in management of postpartum hemorrhage. Misoprostol, PGE1, only uterotonic in tablet form. Misoprostol. WHO recommends distribution of tablet in antenatal period in rural areas to prevent postpartum hemorrhage. Dose: WHO 800 microgram sublingually, more than orally. ACOG 600 to 1000 microgram sublingually, orally, per rectally 1000 milligram. In case of postpartum hemorrhage, misoprostol avoided per vaginally, as it can be washed off. Side effects: hypothermia and shivering, nausea and vomiting. Is contraindicated in scarred uterus, previous history of rupture. Most common drug causing rupture of uterus is misoprostol. Misoprostol can be given to asthmatic patients. Labetalol is not given to asthmatic patients. Carboprost, dineprost, hemabate. PGF2 alpha. Carboprost, dineprost, and hemabate. So, PGF2 alpha, gold standard for management of postpartum hemorrhage is carboprost. Dose 250 microgram IM every 15 to 40 minutes, maximum 8 doses, 2 mg. Side effect: diarrhea. Contraindication: asthma, pulmonary hypertension, amniotic fluid embolism suspected, pregnancy induced hypertension relative. Dinoproston, PGE2, used off-label as PV, PR, suppository, 20 microgram. Not recommended by WHO. Management protocol. Bimanual uterine massage plus injection tranexamic acid plus oxytocin, first drug used as per WHO recommendation. If unresponsive, methylargometrin. If unresponsive, carboprost plus mesoprost add-on drug. If unresponsive after 30 minutes, mechanical compression, continuous uterotonics, principal warm normal saline catheter placed inside uterus, pressure on venous sinuses, controls bleeding, catheter used Buckley balloon catheter, maximum capacity 500 ml, SB esophageal catheter, EBP uterine tamponade system, and condom catheter. If responsive, remove catheter after 12 to 24 hours. If bleeding continues, vitals unstable, uterine artery ligation. Vitals stable, shift patient to operation theater, employ temporary measures, external aorta compression, military anti-shock garment, external aorta compression, absent femoral pulse, aorta compressed, vertebral column, at level of umbilicus, ipsilateral femoral pulse checked to ensure proper compression. Compression sutures, Lynch brace sutures most common, Heyman sutures, Chosquet suture, Pereira suture, Gonzala suture. If bleeding continues, radio intervention present, uterine artery embolism if stable vitals. If no radio intervention presents, stepwise devascularization, unilateral uterine artery ligation, bilateral uterine artery ligation, unilateral anastomotic branch of ovarian artery ligation, bilateral anastomotic branch of uterine artery ligation. If bleeding continues, vitals stable, ligation of anterior division of internal iliac artery. If fails, subtotal hysterectomy, cervix is not removed. Vitals unstable, directly subtotal hysterectomy, cervix is not removed. If bleeding continues, pelvic pressure packs, umbrella pack, parachute packs. Uterine artery ligation, level at site of upward turning of broad ligament, at point where round ligament crosses. Proximity to uterus maintained to prevent injury to ureter. Success rate bilateral uterine artery ligation 85% cases. O'Leary technique, uterine artery suture includes part of myometrium to prevent slipping. Uterine artery. And ovarian artery at the top. Note, shock index is heart rate upon systolic BP. Normal 0.5 to 0.7. Shock index. Shock index more than 0.9, blood transfusion indicated, risk of maternal mortality. So heart rate and systolic BP. You have to divide heart rate, then your systolic BP. Packing of uterus, outdated method for management of postpartum hemorrhage.